So in chapter 2, first we talked about fluid imbalance, and now we're going to talk about electrolyte imbalances. And fluid and electrolytes often go hand in hand because electrolytes exist in they're ions dissolved in fluid in our body. And our electrolytes, they do lots for us, and we're going to talk about it. So this is the little chart with the distribution of major electrolytes in the body between the intracellular fluid, the ICF, and the blood. You can see there's a lot of sodium in blood, there's a lot of chloride in blood, and less in the intracellular fluid. There's a lot of potassium in the intracellular fluid, a variable amount of calcium as it gets used for different things. We'll talk about it. Lots of phosphate because it has to be there for a buffer system, and bicarbonate, which is also part of a buffer system, and magnesium distributed between the intracellular fluid and the blood. So there are a lot of anions and cations in the body. Anions are negatively charged ions. Cations are positively charged ions. They have so much function in our body on just basic stuff like nerve impulses, cardiac function, fluid balance. Electrolytes are major players in the body. So electrolytes move between compartments. We saw that chart with the different compartments they're in. So they move along with water because they're dissolved. They move along with fluids. So hydrostatic pressure and osmotic pressure are pushing and pulling the electrolytes along with the fluid. The other thing that we have in some of our cell membranes is we have specific channels for ions to go through. And we will talk a lot about ion channels in neurology next winter, because ion channels are very important in nerve conduction and conducting a nerve impulse down the neuron. So ions, sometimes they go with fluid, sometimes they have special transport proteins that take them here and there, and sometimes they have special channels that are embedded in the cell membrane. Kind of cool, right? So sodium, good old sodium, it's the primary cation in the extracellular fluid. So sodium diffuses between vascular and interstitial fluids, and it's transported in and out of cells by a sodium-potassium pump. So normally there's more potassium inside the cell, we saw that in the first slide, and more sodium outside the cell. And we have these sodium-potassium pumps that are powered by ATP that pump sodium into the cell and potassium out of the cell. So anytime you have a chemical gradient, you have potential chemical energy. So the cell membrane serves to maintain that gradient so we can do stuff with it. So when you have potential energy, then maybe you could do stuff with it later on. So sodium is actively secreted into mucus and other secretions. Like when you cry, your tears taste salty because they have sodium in them. And a lot of our other body fluids taste salty too. I'm not really tasting a lot of body fluids, but tears. Okay. Went to a weird place there, but now I'm back. Sodium exists in the form of sodium chloride and sodium bicarbonate, mostly in the body. It's ingested in food and beverages. So we have our lovely sodium. I really lately have been really loving the little large flake salt that you get. Sprinkle one or two of those flakes on something, it really changes the dish. So that's how I ingest my sodium in my food. So hyponatremia. Okay, let's cut this word apart. Hypo means low. Natremia is the Latin word for sodium. That's why Na is the chemical name for sodium. It's the Latin word natremia. So hypo, nat is sodium, and emia means blood. So it means low blood sodium levels. Okay, so hyponatremia is caused by sodium losses from excessive sweating, vomiting, or diarrhea. It can also be caused by use of certain diuretic drugs combined with a low-salt diet. So a lot of people who are on hydrochlorothiazide, which is a diuretic that is used to treat high blood pressure, very commonly used drug, and they're on a low-salt cardiac diet, they can have low sodium. There are sodium-sparing diuretic drugs that doctors will often switch people to if they're showing up with low sodium. We'll talk about the effects of low sodium in a minute. Low sodium can also be caused by hormonal imbalances. So aldosterone, which we talked about a little bit with regard to fluid, affects sodium. If you don't have enough of it, you could get hyponatremia. Adrenal insufficiency can affect sodium, and excess antidiuretic hormone secretion can affect sodium, can cause hyponatremia. Diuresis, which is losing fluid because of a diuretic drug, or excessive water intake. So we talked about in the last section how you have to get enough water and you have your thirst mechanism and everything, but excessive water intake actually dilutes your electrolytes, and so you have lower levels than what you really need. So it's a balance, just like everything with homeostasis. You don't want too much, you don't want too little. I would say it's a Goldilocks thing. You don't want it too salty, you don't want it not salty enough. It has to be just right, okay? So hyponatremia, which is low sodium levels, cause fluid imbalance in compartments. The symptoms that come with the fluid imbalance can be fatigue, muscle cramps, abdominal discomfort or cramps, nausea and vomiting, which then can cause more hyponatremia. So, it's a downward spiral. It can cause decreased osmotic pressure in the extracellular fluid compartment, meaning the osmotic pressure is not drawing the fluid into the sodium into the extracellular fluid. You get a fluid shift into cells, causing hypovolemia and decreased blood pressure. So if the fluid is not in the extracellular compartment, it is in the cells, then it's not in your blood, and you can have low blood volume and decreased blood pressure. It can also, decreased osmotic pressure in the extracellular fluid compartment can also cause cerebral edema, which is very serious, and it can cause confusion, headache, weakness, and seizures. Not a good thing. Hypernatremia is the opposite. So hypernatremia is caused by imbalance in sodium and water. So when I was looking through my PowerPoints from last year, I realized that a lot of them didn't have pictures, and I like having pictures in my PowerPoints. And I found all these nifty nursing mnemonics for electrolytes. And you don't necessarily have to memorize them, but I just think they're kind of neat. They have like causes of hypernatremia, and it's the model. Medications, osmotic diuretics, diabetes insipidus, excessive water loss, or low water intake. And that's the model. That's how you remember it. I thought that was kind of neat. It can also be insufficient antidiuretic hormone, which is also known as diabetes insipidus, as opposed to diabetes mellitus, which is the diabetes we usually think of. It results in a large volume of dilute urine. Loss of the thirst mechanism, watery diarrhea, prolonged periods of rapid respiration, and ingestion of large amounts of sodium without enough water. So you have too much sodium in your bloodstream. The effects of it, this one I thought was funny. Fried salt are the effects of hypernatremia. Flushed skin, well, you can read. I'm not going to read all those, but I just thought they were cute. You don't have to memorize them. Hypernatremia can cause weakness and agitation, dry, rough mucous membranes, edema, because there's more fluid in the extracellular space, increased thirst if the thirst mechanism is functional, and increased blood pressure. So the implications for therapy for hypo or hypernatremia are the fact that edema and weakness and agitation are going to make it difficult to mobilize people. So with hyponatremia, low blood pressure, confusion, headache, weakness, seizures, these are all things that are contraindications to therapy. So that's really what we're concerned about, is how is this affecting whether or not we can get people mobile. And it certainly does affect that. Normally when people say you're working in acute care, you look at the labs and you see that somebody is hypo or hypernatremic, and it may affect their treatment. So the first thing I would do if I went and I had somebody with their labs are out of whack, I'd go right to the nurse who's in charge of that patient and I'd say, is this person appropriate for therapy? How are they doing? And that's the correct thing to do for us. Potassium, on the other hand, has far greater implications. So potassium is the major intracellular cation. So we've got sodium outside the cell, potassium inside the cell. The serum levels are low within a narrow range. So we don't want too high potassium in the blood. We also don't want too low potassium in the blood. It's ingested in foods and is excreted primarily in the urine. Insulin promotes movement of potassium into cells. So insulin does a lot of things, but that's one of the things that it does. Potassium level is also influenced by acid-base balance. So we'll talk about acid-base balance in the next section, but there is a balance between potassium ions and hydrogen ions. And so if the acid base, if you're more acidic, you have more hydrogen ions, it's going to affect your potassium. Excess potassium ions in the interstitial fluid may lead to hyperkalemia. So same thing, if we break up that word, hyper is too much, kale is potassium, and emia is blood. Too much potassium in your blood. Hyperkalemia is a serious medical situation. It can affect cardiac function. So abnormal potassium levels cause changes in cardiac conduction and are life-threatening. If somebody's potassium is out of whack, they need to be in the hospital, and something needs to be done immediately. They need medical intervention to get that straight before they have a heart attack. So this is the chart from the book with the signs of potassium imbalance, and it compares hyper and hypokalemia. So hypokalemia is not enough potassium, and hyper is too much. Okay, so as far as cardiac things go, hypo causes cardiac arrhythmias and potentially cardiac arrest. Hyper also causes cardiac arrhythmias and potentially cardiac arrest. So both of these are serious. Your potassium needs to be right. It affects your heart. Both of them can cause nausea. Hyper tends to cause diarrhea, and hypo tends to cause constipation, so they're opposite. And anorexia is the no appetite. So hypokalemia can cause you to lose your appetite. It also affects muscle. So hypo can cause fatigue and muscle twitch and weakness and leg cramps. And hyperkalemia can cause muscle weakness and paralysis. That's huge, right? Just because your electrolytes are out of whack. It affects your breathing. Shallow respirations and paresthesias, which are abnormal sensation, basically. So like tingling, zinging, and so hyper or hypo can cause those paresthesias. You can get, with hypokalemia, you get postural hypotension, meaning you stand up and your blood pressure drops. You can get polyuria, which is lots of urine, and nocturia, which is urinating at night. And hyperkalemia can cause oliguria, which is excessive proteins in the urine. So the serum pH is elevated with hypokalemia, which puts you into alkalosis, metabolic alkalosis. With hyperkalemia, you're in metabolic acidosis, and we'll talk about those in the acid-base section. So potassium has a huge influence on a lot of the body systems, most specifically the heart. So that's why it has really big implications for therapy, and muscle weakness and fatigue and muscle twitch. So people with potassium imbalance are often not appropriate for exercise. So hypokalemia is serum potassium under 3.5 milliequivalents per liter. That's just the lab unit of measure that they use. You don't have to memorize that. It can be caused by excessive loss of potassium because of diarrhea. It can be caused by diuresis associated with some diuretic drugs. So I said that some diuretic drugs spared sodium, some of them spare potassium. Some of them lose sodium, some of them lose potassium. So depending on what drug you're on, you should know what the complications are for those. It can be caused by excessive aldosterone or glucocorticoids. So Cushing's syndrome is a metabolic syndrome, which we will talk about later, that can cause hypokalemia. Increased dietary intake of potassium. It may occur with alcoholism, eating disorders, or starvation. Treatment of diabetic ketoacidosis with insulin can also result in hypokalemia. There's another one of the nursing mnemonics, kind of cute. Good ways to remember things. So the cardiac dysrhythmias, they're caused by impaired repolarization leading to cardiac arrest. That's pretty serious. Interference with neuromuscular function. The muscles are less responsive to stimuli. We're going to get different effects if we're trying to do exercise with them. Paresthesis, which is that tingling pins and needles effect. Decreased digestive tract motility. That's what causes the constipation. Severe hypokalemia can result in shallow respirations and failure to concentrate urine. That causes, more urine, more fluid loss. So hyperkalemia is serum potassium greater than 5 milliequivalents per liter. So we have to be between 3 and 5. That's a pretty small range. But our body in general, except for disease processes, is pretty good at keeping that range. Hyperkalemia can be caused by renal failure, so your kidneys aren't doing their job. Deficit of aldosterone. So hypo was caused by excessive aldosterone. Hyper is caused by deficit of aldosterone. It can be caused by potassium-sparing diuretics. Leakage of intracellular potassium into extracellular fluids can cause it. So people who have extensive tissue damage due to trauma or burns can have problems with hyperkalemia. Displacement of potassium from cells by prolonged or severe acidosis. So there is a relationship between potassium and hydrogen ions. And any problems with acid-base balance can affect your potassium as well. So hyperkalemia causes cardiac dysrhythmias, which may progress to cardiac arrest. Muscle weakness is common, and it can progress to paralysis. It may cause respiratory arrest, impairs neuromuscular activity, fatigue, nausea, and paresthesias, which is that tingling, pins and needles feeling. So hyperkalemia is a very serious, life-threatening condition.